Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on renal and hepatic considerations in older people with HIV, featuring Jonathan Appelbaum, the Laurie L. Dozier Jr. MD Education Director, Professor of Internal Medicine, and Chair of the Department of Clinical Sciences at Florida State University College of Medicine in Tallahassee, Florida, and Jens Lundgren, Professor at Riggs Hospital, University of Copenhagen, and Director of the Center of Excellence for Health, Immunity, and Infection at University of Copenhagen in Copenhagen, Denmark. They'll discuss key considerations for the use of ART in older patients with renal and hepatic impairment. Following their dialogue, the faculty will field questions from healthcare professionals. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Drs. Appelbaum and Lundgren.
Thank you, Jessica. This is Dr. Appelbaum, and I'm going to start off by just sort of setting the context for our discussion around renal and hepatic issues in older persons with HIV. As you can see from the slide, there are more than 51% of persons living with HIV in the United States are over the age of 50. And this is one of the most rapidly increasing segments of our HIV patient panels, partially because of the great treatments we have now, and also, unfortunately, because about a fifth of all new infections in the United States are in this patient population. Just kind of as a review of the ART recommendations across the world, and the good thing is that the guidelines have kind of coalesced around the use of integrase inhibitors as the anchor drugs for all of the regimens. The European guidelines have recently added dolutegravir as a preferred or recommended regimen. And then as a reminder that at least in the studies that have looked at a significant number of persons over the age of 50 in clinical trials, there really doesn't seem to be any difference in the virologic efficacy of integrase-based regimens based on age. So with that context, I'm going to go ahead and turn the segment over to Dr. Lundgren.
Thank you very much, John, and hi, everybody. I hope you're safe in the middle of another wave of the pandemic. So the first area we're going to discussing here is renal impairment. And to contextualize this, we are now talking about a 65-year-old male, which has been living for HIV for quite a number of years and is on rilpivirine, FTC, and tenofovir daily. And the providing physician have noted a gradual decline of eGFR, but have not further characterized that. On the right, you can see the laboratory presentation currently. So clearly the patient is well treated for his HIV, have a good CD4 cell count, at low risk of opportunistic infections, is slightly obese, have slightly elevated blood pressure, is slightly dyslipidemic, as you can see, with a total to HDL cholesterol ratio exceeding 7, has slightly elevated ALT levels, potentially related to his elevated BMI, or there could be other factors, of course. And then, quite concerningly, his eGFR presently is only 25 milliliters per minute. Obviously, this is a complicated case, probably not that well managed previously. His hemoglobin A1C also elevated with 60 millimole per mole, or also expressed as 7.6%. So at least some signs of the patient also have diabetes. So a complicated case, John, but your take on this one. We'll come to the ARV management, but just as giving your background, a few comments on what you are thinking of this patient and what to do.
Yeah, there's lots of things to address here. Lifestyle to try to reduce the BMI. His blood pressure, I know you're going to get into this, but we want to do everything we can to protect his kidneys. And uncontrolled hypertension further can damage his kidneys. And the goal for blood pressure control in patients with renal disease would be probably to get his blood pressure down around the 130/80 range. Addressing his lipids and certainly his abnormal glucose metabolism are also things. So lots of things to work on, and probably some medication adjustment, which I know you'll get into.
Exactly. So, as you say, there's a lot of complex issues within the metabolic arena. But as you also are saying, some of the, for example, the blood pressure could actually further adversely affect his kidney function, which is the topic of today. So we need to think about the totality of risk factors that can further complicate his kidney disease. But I guess the first thing to really emphasize here is that we can't use the eGFR to characterize his kidney disease. We really want to make sure we are understanding whether there is proteinuria as well. We know that for some antiviral treatments, you will see an artificial increase in serum creatinine, so an artificial decline in eGFR. And so if you're in doubt of that, confirm with the objective creatinine clearance. And also make sure to check for proteinuria, screen with a dipstick, and if positive, then do a urine albumin to creatinine ratio, because we know that the combination of eGFR and proteinuria greatly affect the further course of his kidney disease. And this is taken from the European AIDS Clinical Society guidelines released in October last year, and really makes the point that you need to stratify your focus on renal impairment, not only depending on the eGFR, but in particular in people that have also proteinuria, you need to be even more aggressive in that aspect. In terms of his antiviral treatment, we're in a dilemma. His eGFR was 25, and he was on tenofovir. Clearly, that's not recommended in people with an eGFR that low. So we need to find something else. We could consider TAF and FTC in combination. You can use TAF down to 10 in eGFR, but the issue is that you can't use that as a combination pill because you need to reduce the dose of FTC in patient of this type to 200 milligrams every 3 days, as opposed to the usual 200 milligrams at 24 hours. So at least combination of TAF and FTC is not going to be helpful. So there's a lot of things we need to handle in this patient. And obviously, since we are not only dealing with this problem, but also other problems, we probably also need to be very observant about the pill burden and try to minimize his HIV pill burden to the extent possible. A recent study further confirmed that in this instance, 3TC, that you need to dose adjust for people who have reduced creatinine clearance. This was a study published in 2018, 34 participants who have been receiving 3TC for at least 3 months, and then was looking at the observed 3TC maximal concentration to really see whether there is a difference depending on what objective creatinine clearance the patients had. And the good thing is that this seems to be in the same range. But again, just as a reminder to really make sure that if you're using 3TC, that you need to reduce dose in people with impaired kidney function. Of course, another tack would be to have switch the patient to a true drug regimen, which is NRTI sparing. So we have 3 options, dolutegravir 3TC. We can use dolutegravir and rilpivirine. And we can use long-acting CAP together with rilpivirine. And just to go through those studies that would supporting that possibility, you're aware of the Gemini study that showed in patients that started on antiviral treatment that if you were starting people on dolutegravir and 3TC as compared to dolutegravir together with FTC and TDF, viral suppression in both of the Gemini trials was compatible between the 2 arms, but at least there was some suggestion that those who had a tenofovir sparing regimen, that their renal function was slightly less affected. In particular, if you look at the urine renal biomarkers, the protein creatinine ratio that was increasing substantially more in those who were randomized to tenofovir. The TANGO study, another one now in people who were already on treatment, which was randomized to either switch to dolutegravir and 3TC versus continuing a TAF-based ART regimen. Suppression rates was maintained in most of the people at a comparable rate. But again, those who were switched to dolutegravir and 3TC had at least biomarker evidence of improved renal function compared to those who were randomized to TAF, although the differences were not that striking given the evidence that TAF is a less renal toxic agent compared to tenofovir. The SALSA study, switching to dolutegravir and 3TC versus continuing of any three-drug ART regimen, again, a randomized trial, again, compatible mild suppression and outcome data here at week 48 on the left of the slides, but also in this situation here, also a slightly better biomarker profile for those who were randomized to dolutegravir and 3TC compared to those who were maintained on a TAF-based ART regimen. At least some data here based on biomarkers that moving away from TAF and TDF may be actually helpful. The SWOT data as well, which was again in people who was biologically suppressed and then switched to dolutegravir and rilpivirine compared to continuation of baseline ART regimen. Quite strikingly, if you stratify the cohort based on whether they were on TAF, as they came into the study, you saw a substantial advantage by switching, in particular for those who were on tenofovir prior to entering the study, and therefore moved away essentially if they were randomized to dolutegravir and rilpivirine. And then finally, just as a reminder, we have the ATLAS and the FLAIR study, which was looking at long-acting intramuscular cabotegravir in combination with rilpivirine. Obviously, this is a little bit more complicated, or some would argue substantially more complicated regime to do. You need to suppress the patient first with all regimen, and you need to do repetitive injections every month or every 2 months of combination of cabotegravir and rilpivirine. But at least in the two studies, similar biological outcomes. So this is certainly a possibility, although it is more resourceful also for the clinic and the patient, probably not as extensively used as we would have thought maybe earlier because of those slight inconveniences. So this is sort of the data here. Just coming back and remind you, so this patient, he had an eGFR 25, was taking rilpivirine, FTC, and TDF. So no question, something needs to be done in terms of the composition of his antiviral treatment. So probably for this type of patients, changing to dolutegravir and rilpivirine as a single tablet regime is probably the way to go. So, John, I'll turn it over to you. Any comments before we start on your discussion on liver disease you want to bring forward as well?
Oh, no, great discussion, Dr. Lundgren, and totally agree with the approach to this patient, especially since his renal function may be continue to deteriorate. So it's great to have him on a regimen that, once you put him on, you really don't need to worry about as his kidneys deteriorate further. So I'm going to switch gears and talk about liver disease, and in particular, talk about non-hepatitis liver disease in patients living with HIV, something we don't often talk about. So like Dr. Lundgren, I'm going to ahead and start with a case. So this is a 68-year-old who's been living with HIV for 25 years. He's been on multiple ART regimens like many of our older patients. He's got a number of underlying conditions, including hypertension, metabolic syndrome, and arthritis. And like some of my patients, he is wedded to a single tablet regimen that we don't tend to use anymore. But despite the fact that I've tried to get him off of his efavirenz, FTC, and TDF, he adamantly says, no, it's working, and I don't want to change. He's also on metformin, atorvastatin, aspirin, and a combination lisinopril hydrochlorothiazide for his blood pressure. His social history is a former smoker, does drink alcohol socially, and his physical exam is totally normal. And on the right, you see his parameters. His HIV is well controlled, as it was in the last case. His BMI is also in the overweight range, or actually obese, stage 1 obesity range. Blood pressure is pretty good, 128/62. His cholesterol also is elevated. His ALT is 68 and his GFR is 72. So he's got stage 2 CKD, and he's got an A1C of 7.8 going along with his metabolic syndrome. So like a good internist, I've come up with a problem list and listed his well-controlled HIV, his obesity, hypertension, well-controlled metabolic syndrome, stage 2 CKD. He's a former smoker. He intakes a moderate amount of alcohol, and he's got an abnormal ALT, which I've repeated, and it comes back now at 85. So it's about 2 to 2.5 times the upper limit of normal. So a little bit about abnormal transaminases in our patients living with HIV, a couple of studies. The first one is a retrospective study looking at patients with HIV who are monoinfected. So these are not patients with either hepatitis B or hepatitis C. And you get about 15% of patients who have an elevated ALT and about 20% of the 1,200 patients who had elevated ASTs. This was just a randomized single time frame study. The study on the right is looking at a 6-month period of patients, and again, about a little over a quarter had abnormal LFTs, and looking at what the causes were. If you look on the upper right portion of the pie graph, about a third of the patients had non-alcoholic fatty liver disease, or NAFLD, by ultrasound, and a scattering of other causes, including viral hepatitis and alcohol disease. And then there were about 40% of patients who never, at least in this study, didn't have a cause that was found. Now, the American Gastroenterological Association has come up with a clinical pathway to the determination of NAFLD. So it starts with looking at the risk factors. And so we're going to get into this a little while, but things to look for in patients who might have non-alcoholic fatty liver disease would be some risk factors, including type 2 diabetes mellitus, any abnormal fatty infiltration on imaging, and of course, elevated transaminases. In evaluating them, you also want to make sure that there isn't a history of excessive alcohol intake. And then you start with non-invasive tests, the FIB-4, which is a calculation based on AST, ALT, platelet count, and patient's age. It's a calculated test. I actually have an app for it. You can Google FIB-4 and download the app, but it's a very easy screening test because it uses readily available biochemical markers that all of us get. Depending upon the results of the FIB-4, it places the patient in one of 3 categories. If the FIB-4 is low, they're probably at low risk. And if the FIB-4 is either high, it puts them at very high risk for NAFLD. The intermediate range, about 1.3 to 2.6, usually means that you have to go do another test, and we usually recommend some sort of a evaluation for liver stiffness. Again, it's a test that can be done as an outpatient, doesn't require any invasive procedure to the patient. Important to assess for other liver disease, the big key would be alcohol. So trying to get a decent history from the patient on alcohol intake, any signs or stigmata of chronic liver disease, and then of course you want to rule out hepatitis. Screening for hepatitis C with a hepatitis C antibody, but you might want to follow that up actually with a hepatitis C RNA, consideration for hepatitis B, and then do an evaluation for autoimmune hepatitis, hemochromatosis, or alpha-1 antitrypsin deficiency. Rare causes, but things that you want to consider. And certainly if you find another cause of liver disease, you're going to treat that accordingly. But if no other cause is found, then you're going to probably want to go ahead and do non-invasive testing for fibrosis. Now, the finding of fatty liver can be secondary to things like alcohol and drugs or some of the hereditary disorders, or it can be from non-alcoholic fatty liver disease. And on the right, you can see that some of the clues would be patients who are overweight, have diabetes, hypertension, or hyperlipidemia are more likely to be the non-alcoholic fatty liver disease. And NAFLD can be divided into simple fatty liver infiltrate, or NASH, which is fatty liver with inflammation and concerns about further development of things like cirrhosis. And this is just a graph to show you that liver disease is increasingly common in our older patients living with HIV and has increasingly become a cause of death in our older patients with HIV. So it's not something that we can ignore. Prevalence of NASH, which is a little more concerning for development of chronic liver disease, depending upon the part of the world. You can see in the United States up to 55% of patients had NASH on liver biopsy with abnormal liver function tests. And it does vary in other parts of the world, less in the United Kingdom, perhaps about the same in France. So the prevalence of fibrosis, which it would be even more concerning, is less. So there's more fatty infiltrated and probably fewer patients going on to liver fibrosis. But the concern about liver fibrosis is the development of cirrhosis and end-stage liver disease. And you can see in the United States, it's less common than in other parts of the world. So what is the chances of a patient with NAFLD progressing to fibrosis? This is a study looking at one particular treatment. This is looking at the group of patients who did not get the treatment. So basically the placebo group. And while 50% of the cohort, and it's a small number, it's only 24, 50% did not progress over the period of the study, which I believe was about a year. 38% progressed. That's pretty significant if over a third of patients with NAFLD would progress over a short period of time to fibrosis. Regarding some of our treatments for HIV and the development of fatty liver, the good news is that if you look at this study, looking at 4 different integrase inhibitors, between the start of exposure and the end of the exposure, there really wasn't much change in these are non-invasive scores for fibrosis. There really wasn't any change. And this was looking at about a 2-year period in 110 patients. So the good news is that it looks like integrase inhibitors don't have any effect on the progression of fibrosis. And then we always have to remember that many of our ART regimens are hepatically metabolized. And so depending upon the amount of hepatic involvement, it may require dosage adjustments. So if you have mild liver disease, the recommendation is to decrease abacavir, but efavirenz probably shouldn't be used. They recommend using it with caution. And atazanavir and cobicistat is not recommended. As the liver impairment worsens, then you have more concern around some of the antiretrovirals. And then finally, if a patient has child PUC, then there are drugs that really should be avoided, but then there's drugs where no dosage adjustment needs to be made. So some of the metabolic complications that we're seeing in our older patients with HIV and the risk factors for NAFLD actually are very similar. So as we mentioned, the risk factors for non-alcoholic fatty liver disease include hypertension, dyslipidemia, and insulin resistance, many of which we see in our older patients living with HIV. So what do we do at this point? Recommending lifestyle modifications, obviously trying to control the comorbidities as much as possible, and obviously avoiding any hepatotoxins, canceling our patients on alcohol intake, excessive acetaminophen ingestion, and making sure that we're doing our best to reduce any drugs that could potentially have hepatotoxic effects. And then regarding the NAFLD-associated conditions, we want to make sure that we're not using ART that can further impair the patient's liver disease. So switching to integrase-based regimen would certainly be reasonable. And that was, one of the things that I was able to use in this particular patient to convince him that it's time to get him off the efavirenz. And at the one point that I really want to make is that if you look at patients with non-alcoholic fatty liver disease, the most common cause of death is cardiovascular disease. So paying attention back to the comorbidities and the traditional cardiac risk factors is certainly a key feature in caring for patients with non-alcoholic fatty liver disease. So going back to our patient here, his blood pressure was pretty good. A1C was still a little high, so maybe he's kind of tipped over from metabolic syndrome to diabetes, so we might want to do a better job of getting his A1C down, managing his cholesterol, and as I mentioned before, getting him off of efavirenz and switching him to an integrase-based regimen. So just kind of to sum up before we open for questions, and by the way, please submit your questions. So renal impairment can warrant NRTI dose adjustments or consideration of NRTI sparing regimens, and some of our 2-drug regimens may help simplify this for our patients with renal impairment. NAFLD is increasingly common in older patients with HIV. So the finding of elevated transaminases is an indicator, plus other comorbidities that might increase the risk. And remember that cardiovascular disease is the most common cause of death in our patients with NAFLD, and that we may need to consider ART modifications to decrease the risk and accommodate hepatic impairment. So questions?
No, John, thank you very much. This is Jens. I can see that there's several questions in the chat. First ones are really pointed for you. Kathy Melbourne is asking, Dr. Appelbaum, how do you motivate your patients to change diet and physical activity to lower their risk of poor metabolic outcomes and liver disease? Also, what tools do you use to help change behavior?
Hi, Kathy. I haven't seen or heard from you in many years, so nice to see that you're around. Good question. Not only is it a good question, I think that's the $1 million question, right, Jens?
Yeah, no, I agree.
So I have a few years doing this under my belt. I can't say I've always been successful. I try to use some techniques of motivational interviewing very briefly, if I can. I also make use of other members of the team and working with a dietitian, working with my nurse practitioner and case manager. So I think this has got to be a team effort.
Difficult question. So Yenti Serrano is asking, what antiviral regimen would be the most appropriate for a patient with high transaminase? And efavirenz may not be the most optimal in this particular patient, but which other antivirals are you intensely trying to avoid in people who have NAFL?
Yeah, so I'm obviously avoiding efavirenz. I am in boosted PIs, particularly boosted atazanavir, which I haven't used in years. I've used integrase. If it's possible to go with a 2-drug regimen, I think fewer drugs, less likely to cause any liver problems. So that's kind of where I'm coming from. I don't know about you, Jens.
No, I would agree. The point you're making about addressing comorbidities and lifestyle factors are probably more important. I remember back in the early days of HIV Care, we had some pretty hefty hepatotoxic agents, but they're all phased out. So you have stavudine, for example, or DDI. These were not helpful to the liver.
Absolutely.
And there's actually still, in people who were treated at that time, we can still track that the liver disease induced by that drug supposedly is still maintained quite a number of years after having stopped it. So it's always good to go back for those who has been treated a long time to see how they actually treated back in the 90s and the early part of this century, because we were not using necessarily good drugs at the time, obviously not knowing it.
I remember those days. So now, I also want to make one other point. I know this is not a talk about treatment for NAFLD, but let me suffice it to say that there really aren't any great treatments for NAFLD. So, the point that I'm trying to make around lifestyle modification and trying to reduce any potential damaging behaviors and treatments to the liver is really all we've got right now. There are a number of drugs in development, but many of the treatments that have been tried in the past really have not worked.
So we talked at another earlier conference, John, and your point about making sure that although we are focusing on liver, make sure you treat the patient in totality, including whatever else is there. And the point about cardiovascular disease as a major factor also in people with NAFL, make sure you treat a cardiovascular disease risk factor. It's obviously critically important. We're getting to the end here, but I would really like to discuss with you, John, one question Sanjeva Palavela is asking. And I think he's referring to the patient I presented. Should this patient, in view of his hypertension, of type 2 diabetes and chronic kidney disease, be on an angiotensin receptor antagonist or an ACE inhibitor? And there's also a question about vitamin D and NAFL. But if we focus on using drugs to protect the kidney function, because there's actually been some evolution in that area. And it's correct that angiotensin receptor antagonists or ACE inhibitors were been shown, what's called the SGLT2 inhibitors, I think now being further recognized also to have that, and therefore drugs that you want to potentially consider in people who have type 2 diabetes and impaired kidney function.
Yeah, I know. I agree with you 100%. And particularly the question about ACE inhibitors or ARBs, particularly if the patient has proteinuria. I think that's a really good point. And, you're going to kind of take care of two problems at the same time, protect the kidney and also help lower the blood pressure.
Exactly. So that was actually a good point to bring out here.
And the question about vitamin E, it's been
what do you
tried.
say to that?
It's been tried, but there's really no great evidence that it works. There's a whole bunch of drugs that have sort of fallen by the wayside. The pioglitazones, the anti-diabetic drugs. I think some people still will put patients on vitamin E, but there's really no data that says that it's helpful.
I agree. So Yunus Mosa is asking, I think, which is a straightforward question, would you use rilpivirine in a patient with NAFL?
I would probably be okay with that.
Yeah, no, that would be my sense as well. There's another question. Maybe this is one Peg Nelson is asking, do you use cabenuva in older patients, and do you have any concerns in relation to renal and hepatic impairment?
I don't have any concerns about renal impairment. That's one of the nice things about cabenuva, right? It doesn't require any renal dosing adjustments. I have not personally used it in older patients. Still waiting for my first older patient to agree to it, but I don't have any concerns about it. What about you, Jens?
No, I don't neither. I agree with your answer. John, thank you very much for the discussion. And I think we can turn it back to Jessica to say goodbye. Thank you.
Thank you.
Thank you to Drs. Appelbaum and Lundgren, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.